Hi, my name is Katie Groechel, and I'm a nursing student at the University of Michigan. Today I'm going to tell you about a patient at the Heartland Medical Center. Patient is a 63-year-old married Caucasian female. Her former job was as a social worker, but she has been out of work since 1997 due to a kidney transplant. Patient was admitted to the University of Michigan Hospital on January 2, 2013. She was admitted for extreme shortness of breath. She also states that she has fluid overload or hypovolemia, hypertension, and atrial fibrillation. She states that she believes these problems are from the kidney transplant that she received in 1997. She received the transplant because of kidney failure. She has had atrial fibrillation all her life, though. Patient almost died 3 times on 3 different occasions because of her transplant. Patient was transferred to Heartland Health Care Center from the U of M Hospital on March 14, 2013, to receive physical therapy as well as occupational therapy in the hopes of gaining her independence in daily activities once again. Patient has a history of type 1 diabetes, and she also has been diagnosed with hypertension. She was diagnosed with type 1 diabetes in her 20s. She is in control of it and uses an insulin pump. All patient immunizations are up to date, and she has stated that she has no known allergies. Since being at Heartland, patient has acquired C. diff and is currently receiving medications, but she could not remember the name or the dose of the medications at this time. Patient is on numerous anti-rejection medications, such as cyclosporin, Norel, prednisone, and meterazole. Patient has also taken aspirin to prevent heart problems and blood clots. Patient is on antibiotic vancomycin and is also taking Lasix. Patient was unable to recall the doses of each of these medications, however she keeps a list of them and double checks with the nurse and doctors before taking any. Patient attends physical therapy for 45 minutes every day and occupational therapy as well for 45 minutes every day. Patient states that she has no problem with alcohol or tobacco. She is very alert to her surroundings and her current patient medical care. She follows what the nurses and doctors do very carefully. Patient states she has no current sleeping problems and is able to turn herself in bed. Patient appears to be healthy and says that she eats healthy because of her diabetes. Patient has been married for 40 years and has no children. She lives in a residential neighborhood with her husband and has family and friends nearby. Patient's mother also had a history of type 1 diabetes. Her father's history was not mentioned. Both patient's brother and sister were diagnosed with atrial fibrillation as well. Patient was alert and orientated ×3 and is allowed to be up ad lib. Her blood pressure is 112/72. Her heart rate is 72 beats per minute. Her temperature could not be taken at this time. Pulse ox was 98% on 0.5 liters of O2 via nasal cannula. Patient's cardiac history consists of atrial fibrillation, hypertension, and fluid overload. She was admitted to the U of M hospital in January because of extreme shortness of breath, and the doctors told her that she has fluid overload or hypovolemia. She also has a history of high blood pressure and hypertension. Because of these conditions, doctors wanted to put in a defibrillator, but because of the patient stayed educated on her condition and had to deal with such problems in the past, she refused the procedure for the time being because she believed she did not need it. She was put on a heart monitor and her intake and output was measured carefully. Nurses found no substantial problems in her eyes and nose, and doctors announced that there was no reason for the defibrillator. Since then, her heart has been monitored closely, and she has been on medications for her hypertension and her breathing has returned to normal. Because of her hypovolemia, patient states her chest felt uncomfortable and that nothing would really alleviate the pain. However, at times, aspirin made it a little bit more comfortable. Upon assessment of our cardiac system, heart sounds over the 5 areas were all normal S1, S2 sounds. However, an abnormal S3 sound was found over the mitral valve during auscultation. No abnormal S4 sounds were found. Upon palpation, no buries or heaves were found. Because all heart sounds were normal, as predicted, her heart monitor was no longer needed and was removed. Patient has had no respiratory issues before being hospitalized in January when she developed a respiratory infection that caused fluid in her lungs. Since she has arrived at the Heartland Medical Center, her lungs have been documented as clear. However, she has been placed on oxygen and is currently receiving 0.5 liters, which she receives via nasal cannula. Her pulse ox is around 89 to 90% without the O2, and they are currently trying to taper her off of it. Patient states the oxygen makes it easier for her to breathe and she feels less pressure in her chest. Upon assessment of her respiratory system, we found her trachea to be in line, no injuries, her chest was symmetrical, and upon inspiration and expiration, her chest rose and fell evenly. Patient was negative for tactile femoris. Upon auscultation, both anteriorly and posteriorly, all findings were normal. Patient was tested for bronchophony and egophony and was found to be negative for both, which shows that there are no longer fluid in her lungs. Based on the patient history, a peripheral vascular exam is also pertinent. It is important to assess patient circulation because of patient's history of type 1 diabetes. People diagnosed with diabetes are more likely to have poor circulation due to poor insulin control. This could cause ulcers or sores that won't heal, or severe skin breakdown that could cause more problems for the patient and also infection. Patient also has a history of hypertension within the last 10 years, and it would also be important to assess the strength of each pulse and make sure they are not graded higher than normal. Based on patient's history, a musculoskeletal exam is also pertinent. It is important to assess the progress patient is making while at Heartland, since the reason that she is there is for physical and occupational therapy. I would expect to find weakness in her lower limbs due to her inability to walk during her stay at the U of M hospital. The purpose of the rehabilitation is to get her back on her feet and allow her to carry out daily living activities.